Hello and welcome everyone. My name is Daniela Kwiatkowski and I am the Manager of Training and Development here at MHS. Thank you for joining us for today's webinar, New Ways of Assessing Impairment Through the Use of the Rating Scale of Impairment. Just a few logistics before we get started. You are all on mute so that we can maintain the background noise to a minimum. However, we do want to hear from you. So please ask questions at any point throughout the webinar. There is a question pane in the webinar panel on the right-hand side of your screen. At any point during the webinar, please type in your question and we will do our best to answer all questions. We've reserved a bit of time at the end to do that. If we don't get a chance to respond to your question today, we will make sure that we email you a response afterwards. Also, you will see on the right-hand side of your pane a handout section. There are 5 handouts in there. Please download those handouts at some point during today's webinar if you want to have copies of the reports, the brochure, and this particular presentation. We have included a copy of the presentation as well. Once the webinar is over and we close out the webinar panel, you won't be able to download the handouts at that point. So if you want them, download them now. We will also be sure to include them when we email you the Q&A in the next little while. So if you don't get a chance to do that, please don't worry. We will make sure that we get those to you. We are also recording today's webinar. So if any of your colleagues didn't get a chance to attend, we will let you know when that recording is available for them to view. We are finalizing our schedule of webinars for 2017, so look for an email in your inbox in the next little while to see what topics we'll be presenting on. Later today or early tomorrow, you will receive an email with a link asking for your feedback on this program. Once you submit your feedback, you will be prompted to generate your certificate that will provide you with the CE and CPD information that you need to claim your credits. Now a little bit about who we are for those of you who are meeting us for the first time. MultiHealth Systems is a global publisher of scientifically validated assessments in the clinical, education, public safety, and talent assessment markets. We are located in Toronto, Canada, and we've been in business for over 30 years. We publish assessments in over 50 languages and have a presence in 75 countries around the world, so we are truly global. The reason we highlight all of the markets we work in is that we use the same scientific rigor when developing our talent assessments as we do when we develop an assessment in the clinical world, where the stakes are higher. So we need to be 100% accurate when we're developing a test that assesses autism in children, for example, and we use that same process when we develop our talent assessments as well. So now I'd like to introduce today's presenters. Amy Patenaude is an educational assessment consultant here at MHS. Prior to joining MHS, Amy worked as a school psychologist for Hillsborough County Public Schools in Tampa, Florida. She completed psychoeducational evaluations to address academic and social-emotional needs of youth and collaborated with parents, educators, and other professionals to create safe, healthy, and supportive learning environments for all students. As a school psychologist, Amy worked as a positive behavior supports, PBS, coach, and response to intervention multi-tiered systems of support, RTI MTSS, facilitator. Her areas of expertise include assessments, RTI MTSS, PBS, parent training, and crisis intervention. Amy earned her educational specialist and master's degrees in school psychology from the University of South Florida. She is nationally certified school psychologist, NCSP, and a licensed school psychologist in Florida. We also have on the line today Dr. Lindsay Ayerst. She is a lead research scientist here at MHS for the Clinical Education and Public Safety Divisions. She is the lead or co-author of over 20 peer-reviewed publications, as well as 1 edited book chapter in the Handbook of Assessment and Treatment Planning for Psychological Disorders, 2nd edition, on evaluating the psychometric properties of psychological measures. She's an ad hoc reviewer for a number of scientific journals, and in 2017 will join the editorial board of psychological assessment as a consulting editor. Dr. Ayerst has been with MHS for 4 years, but has over a decade of experience in test development and assessment. I'm now going to hand it over to Amy.
Thanks, Daniela. Hi, everyone, and welcome to the webinar, and thank you for participating today. Over the next hour and a half, we will be discussing the Rating Scale of Impairment, or the RSI, and how you can use it in practice to help with the identification of youth's functional impairment. I'm going to go ahead and turn it over to Lindsay for the first poll question.
Thanks, Amy. So we always like to get a sense of who's on the line with us for our webinars. So we're going to put up a poll question that's asking what setting you work in, and we're going to post that poll now. So you should be able to see it on your screen and you can start responding to it. Okay, so it looks like the majority of people on the line with us today are from a school setting or in private practice, so that's great. We'll do our best to try to tailor our information presented today to make sure that it is appropriate for the majority of our listeners.
Excellent. Thanks, Lindsay. Thanks, everyone, for responding to the poll question. Now, as we get into today's webinar, we have several learning objectives that we're going to be covering. The first thing we're going to be looking at is how impairment is defined. Specifically, we're going to look at how impairment is defined across several different disciplines. This includes the medical field, mental health field, and education field. Then, we are going to look at why the assessment of impairment is critical to a comprehensive evaluation. Now, this includes looking at both the past practices and current practices. Next, we will look specifically at the Rating Scale of Impairment, or as I will refer to it, the RSI, and this will include looking at its key features. Then I will turn it over to Lindsay, and she will discuss the psychometrics of the RSI. After covering these learning objectives, we will discuss the administration, scoring, and reporting features that are available with the RSI. Finally, you will gain experience in the interpretation process of the RSI through a case study example. I'll be introducing to Megan later on in the presentation. Now, based on the remaining time, Lindsay and I will do everything we can to answer any questions that you have and submit. We're more than happy to answer any questions related to the RSI as well as how you assess for impairment. Now, one of the common questions that I've heard, and I've even asked myself as a practitioner, is what is impairment? Well, it's not surprising that defining the term impairment is easier said than done. The term impairment is used differently across the disciplines. This includes the medical field, the mental health field, and education fields. For example, in the mental health field, it is defined as a functional limitation imposed as a result of a psychological disorder. Now, in contrast, when we look at impairment in the medical field, it's defined as an adverse level of physical functioning within the body. Lastly, when we look at the education field, typically, when we're talking about impairment, it's related to one's level of adaptive behavior and intellectual functioning. Well, in reviewing these definitions, it can be confusing for those who work directly with the youth what his or her impairment may be, as well as what the different professionals mean when he or she says that the youth has an impairment. Based on all of the information and research conducted by the authors of this measure, who I'll be introducing you to later in the presentation, Dr. Naglieri and Dr. Goldstein proposed the following definition for the construct of impairment. Impairment is the reduced ability to meet the demands of life because of a psychological, physical, or cognitive condition. Now, this operational definition of impairment is used in the RSI. As you can see from this definition, it really encompasses what different disciplines propose when defining impairment, and it provides practitioners with a common language. Now that we've looked at how impairment is defined for the RSI, you may be asking yourself this question: what are the current practices in assessing impairment? Why is this critical to a comprehensive evaluation? But before we get there, I want to hear about your experiences with another poll question. Lindsay, take it away.
So we thought we'd ask you, how are you currently assessing impairment in your practice? So you can see the response options up there, and if you want to take the time to respond to the poll. Thanks everyone for responding. So it looks like the majority of you are administering a rating scale, but some of you are doing it through direct observation, and some aren't currently assessing impairment formally. So Amy, I turn it back to you to tell us about assessing impairment in the diagnostic process.
Well, it's really interesting because when it comes to assessing for impairment, there's a history behind it. Let's take a look at that history to see what we've done in the past, as well as what we're currently doing as part of the diagnostic process. Now, the role of impairment as a clinical significance criterion was first introduced in the DSM-4. This criterion requires that the individual exhibits clinically significant distress or impairment in social, occupational, or other important areas of functioning. Now, with the DSM-4 TR, practitioners were able to evaluate impairment using the Global Assessment of Functioning Scale, or the GAF scale. Now, the GAF scale represented the clinician's judgment of an individual's overall level of functioning in everyday life. Well, subsequently, the GAF was dropped from the DSM-5. Instead, the authors of the DSM-5 referred to the World Health Organization Disability Assessment Schedule, or the WHODAS 2.0. Specifically, they referred to the WHODAS 2.0 in the Emerging Measures section of the DSM-5 as an assessment of disability and impairment requiring further study. While the WHODAS 2.0 is based on and reflects the concepts that underlie the World Health Organization's framework of functional impairment. This is referred to as the International Classification of Functioning, Disability, and Health, or ICF. Currently, this method of assessing impairment is only utilized with adults. So using the guidelines provided by both the DSM-5 and ICF, impairment has been evaluated by direct observation. While this method is effective, it has been criticized for inter-rater reliability limitations. Also, with both of these methods, they're typically utilized with adults only and not children. This really highlights the need for a multiple rather than singular measure to evaluate impairment in youth. Mental health disorders consistently rank among the conditions that lead to the greatest levels of impairment. Now, in order to provide a diagnosis, there's several things we must consider. We must consider the symptoms that the client is experiencing, as well as the client's level of impairment. Both of these pieces are critical when it comes to providing a diagnosis. Now, according to the DSM-5, mental health disorders are defined as usually being associated with significant distress or disability in social, occupational, or other important activities. And this criterion for clinical significance requiring distress or disability is present in the majority of the symptom criteria lists in the DSM-5. Therefore, evaluation of one's level of impairment is critical as part of that diagnostic process. Now, we've talked a lot about impairment and why it's critical to assess it in our evaluation process, but I want to give you an example from an actual case. Let me tell you a little bit about John. John is 14 years old and he recently started high school. And there are some concerns that his parents as well as teachers have for him. Recently, his parents read an article about autism and started to wonder, does John have autism? Well, here's some of the things that they shared with us. John has always been a loner and tends to keep to himself. He seems to have friends in both elementary and middle school. However, most of his friends really just interacted with him due to his love of Pokemon. His friendships and those relationships all centered on that love of Pokemon and playing Pokemon. From a young age, John has been on a schedule both at home and at school. Now, any deviations from the schedule often lead to massive meltdowns for John. He really has difficulty, according to his parents, with shifting his expectations and displaying flexibility. As mentioned earlier, John is fixated on Pokemon. That's really all he talks about. John seems capable of handling things. However, with this recent transition to high school, his behaviors appear to have manifested themselves. Now, one of the things we wanted to do with John to get an idea of his symptoms is we administered the Autism Spectrum Rating Scale, or the ASRS. Now, this was really designed to assess his parents' concerns and the symptoms related to ASD. While this is an excellent tool for determining whether or not he has the symptoms for ASD, we still need to determine whether or not he has a significant level of impairment in a major area of life functioning. Now, as a practitioner, it sounds like John may have autism. However, I'm asking myself, is he really experiencing that significant level of impairment? Well, stay tuned, because we know John has these symptoms, but we're going to learn later on in the webinar what his impairment looks like. Now let's go ahead and shift our focus and look at the key features of the Rating Scale of Impairment. The RSI is authored by Dr. Sam Goldstein and Dr. Jack Naglieri. Both are well known and regarded in the field for their contributions. One of the things I always encourage practitioners to do is visit both of their respective websites, because there are a host of resources, articles, and just information that may benefit you in practice. Now, there are several key features that make the RSI an excellent tool to add to your repertoire. We've attached the RSI brochure as an attachment that you can access and download as an attendee for today's webinar, and I encourage you to download that resource now. The RSI takes 5 to 10 minutes to complete, depending on its format. This assessment tool was designed to measure functional limitations across a range of life areas for any child or youth between the ages of 5 and 18. Now, with a normative sample, it allows you as the clinician to effectively compare an individual to a nationally representative sample. The RSI also has strong psychometric properties, which Lindsay is going to be talking about later on in the presentation. The RSI measures the impact of a psychological, physical, or cognitive disorder, and this tool can be used with any symptom-based diagnostic tool when forming a diagnosis. It can be used when you're looking at a diagnosis, whether it's for both the mental health field or a medical field. Some additional key features of the RSI include that it's available in both English and Spanish. You're also able to monitor the youth's functional impairment across time and compare change over time. It's a great progress monitoring tool. When using DSM-5 criteria, you're able to determine if the individual exhibits clinically significant distress or impairment in a major area of life functioning. There is a multi-rater perspective with the RSI, as there's both a parent version and a teacher version. The results of the RSI are beneficial and can help you when it comes to forming intervention plans and treatment plans for the youth. This can help with guiding your diagnostic decisions. Lastly, the RSI is aligned with and reflects the concepts that underlie the World Health Organization's domains of functioning found in ICF, or as I mentioned earlier, the International Classification of Functioning, Disability, and Health. Now, I know many of you are in private practice or school psychologists. There are several uses that you can utilize the RSI for. Of interest probably to everyone on the call today is the fact that you can use it to assess individual students. Now, the RSI can be used during the assessment and diagnostic process for both mental health and medical conditions to provide information on the extent of an individual's functional impairment in different life areas. The second option when using the RSI is you can use it to screen a small group of individual students or youth. So in some instances, you may wish to obtain information about a group. For example, the RSI can be used to screen children or youth to identify those who might require additional assessments or benefit from additional supports. The third way with which you can use the RSI is to evaluate the effectiveness of an intervention program. Results from the RSI can inform decision-making about whether or not an intervention is effective. Lastly, you can use the RSI in a research context in a variety of settings and for a variety of different studies you may be conducting. Now let's go ahead and talk about the structure of the RSI. There are two age groups that the RSI is broken down into, ages 5 to 12 and ages 13 to 18. The RSI is designed to be given to both parents and teachers. Now, the parent form consists of 41 items or 49 items, respectively. It takes approximately 10 minutes for a parent to complete. Now, the teacher version consists of 29 items and takes approximately 5 minutes to complete. I love the fact that when I give it to a parent or a teacher, it's pretty efficient with our use of time. There are several different scores that you're able to obtain from the RSI, and this reflects the different scales that comprise each of the forms. As you can see here, there are more scales on the parent version. There's the school, social, mobility, domestic, family, as well as there's the self-care scale on the parent form for the 13 to 18-year-olds. And the teacher form is designed to assess youth in the areas of school, social, and mobility. Now, these scale scores combine and provide us with a total score. The RSI yields T-scores. These T-scores indicate the youth's level of impairment. Higher T-scores indicate higher levels of impairment for that youth. The nice thing with T-scores is that you're able to look at the results and compare them to other assessment pieces of data that you've collected. Now, when it comes to administering the RSI, these are the directions that you would see as a parent or a teacher completing it. We're asking the individual to rate the youth's behavior over a 4-week period. And there's a 6-point Likert scale with which they can select the responses for. Now, we've gone over T-scores and the directions. Let's look specifically at the scales, and let me give you some descriptions for each of the scales. There are 6 scales that the RSI assesses, depending on the form. The first scale is the school or work scale. Now, this scale is designed to assess the youth's level of impairment when acquiring and applying knowledge at school and work. The next scale is the mobility scale. Now, the mobility scale is designed to assess the extent to which the youth has an impairment when physically moving. The third scale is the family scale. Now, this scale is designed to assess the youth's level of impairment when interacting with his or her family members. The fourth scale is the social scale. The social scale looks at the youth's level of impairment when interacting and communicating with others. The fifth scale is the domestic scale. Now, this scale describes the youth's level of impairment when completing household tasks. The final scale is the self-care scale. This looks at the extent of the youth's impairment when it comes to taking care of himself or herself. The scales combine and are what provide us with that total score for the RSI. Now, I want to reiterate again that while there are 6 scales for the RSI, not all the scales are in each of the forms. For example, the teacher form only includes the school work scale, the mobility scale, and the social scale. Now, the self-care scale is only on the parent version of the 13 to 18 form of the RSI. I think this is important to point out because we wanted to ensure that the items on the RSI were developmentally appropriate. Now I'm going to go ahead and turn it over to Lindsay, and she's going to talk about the standardization, reliability, and validity of the RSI.
Thanks, Amy. So I'm going to start by talking about our standardization sample. So data collection took place from September 2012 until August 2014, and data was collected in all 50 states across the US. So the RSI normative samples are representative of the US population of children and youth. The norms are evenly balanced across age and gender, and we used a stratified sampling plan to make sure that race, ethnicity, state of residence, and parental education level matched with the US Census. Over 8,000 ratings were completed across the 4 RSI forms when you combine across the normative sample and all of the reliability and validity studies we did. So of all of the RSI ratings collected, 2,800 of them were included in the normative samples, with 800 for each version of the 5 to 12-year-old forms, and 600 ratings for each version, 600 ratings for each version of the 13 to 18-year-old forms. Turning our attention to reliability, first going to talk about the internal consistency of the RSI. So internal consistency refers to how well the items hang together. In the case of a multi-dimensional scale like the RSI, the items that contribute to each scale should be related as a result of their association with the underlying factor measured by that scale. So here I've reported ranges across the parent and teacher forms within the normative and clinical reference samples. So for the social scale, for example, coefficient alpha ranged from 0.86 to 0.89 in the normative sample, and from 0.87 to 0.92 in the clinical sample. So assuming scores in the range of 0.8 are considered excellent, and anything above 0.70 is acceptable, you can see that overall, the RSI scales demonstrate excellent internal consistency reliability in both our normative and clinical reference samples. We also explored test-retest reliability. So scores obtained on 2 separate administrations for the same child and youth by the same rater over a period of 14 to 30 days were correlated to determine the consistency of test scores over time. Corrected correlations ranged from 0.85 to 0.97 for the RSI scales, and from 0.89 to 0.96 for the total scores, suggesting that the scores, in the absence of any expected treatment effects, are stable over time. So what this means is that you can be confident in that any changes you see in the scores are due to real changes in the level of impairment and not due to the test itself or measurement error. Finally, we explored the inter-rater reliability of the test scores, meaning we explored the degree of agreement between 2 raters of the same child or youth. So for example, 2 parents rating the same child. And there was substantial agreement between 2 parents rating the same child. There's also moderate agreement when 2 teachers rated the same child. It's quite typical to find only moderate associations between raters, as each person has a different and unique perspective of the child and different interactions with the child. So typically you hear about an average inter-rater reliability around 0.6. So these coefficients presented are comparable to that, and actually in the case of the parent ratings, even higher than what one might have expected. Turning our attention to validity, or whether the RSI measures what it purports to measure, we examined the scores for samples of children and youth with clinical diagnoses and contrasted their scores with those of children and youth in the general population sample. We compared individuals with specific types of primary diagnoses, be it mental, intellectual, or physical, in order to demonstrate that the RSI scales are able to measure impairment found in various forms of psychopathology. For example, ADHD, autism spectrum disorders, mood and anxiety disorders, etc. What we found was that across both the parent and teacher forms, the RSI was sensitive to impairment in specific disorders. So for example, children with ADHD showed impairment in the school work domain, and children with autism spectrum disorders showed impairment in the social domain. So that children and youth with various diagnoses demonstrated really different patterns of scores than those from the general population provides support for the criterion-related validity of the RSI. We also looked at individuals based on the number of diagnoses that they had, ranging anywhere from 1 to more than 4. Looking at the number of diagnoses, the goal here is to demonstrate that as the number of diagnoses increases, we'd also expect functional impairment to increase. So in other words, we'd expect that individuals with a greater number of diagnoses would have higher RSI scores than those with fewer or no diagnoses. Once again, consistent with our expectations, scores from the general population were close to 50, indicating no impairment, and scores from children in the clinical sample generally became progressively higher as the number of diagnoses increased. So you see that the bar graphs get taller from left to right. You see this pattern here on the child-parent form, and again here on the child-teacher form. The same pattern also appears for the youth form, and again on the teacher form. So this provides further evidence for the validity of the RSI. We also looked at criterion validity by examining the relationships between RSI scores and scores obtained from other assessments, including measures of impairment, psychopathology, adaptive behaviors, social and emotional competency, and cognitive functioning. With respect to other measures of impairment, we looked at the Children's Global Assessment Scale. So this is a measure of the overall level of functioning and severity of impairment in a child or youth aged 4 to 16 years. It's completed by the clinician, and it consists of a single item assessing the youth's most impaired level of general functioning during a specific time period, and the score ranges from 0 to 100. Unlike the RSI, the CGAS is scaled so that lower scores indicate poorer functioning. So we'd expect a negative correlation. As RSI scores are higher, CGAS scores should be lower. And this is what we found. The CGAS clinician ratings had a negative moderate correlation with level of impairment as measured by the RSI. So the scores ranged from about negative 0.34 to negative 0.51. These moderate correlations could be due to the fact that the two measures are completed by different raters who have different experiences with the child. So whereas the RSI is being rated by parent and teachers, we're comparing it to a single clinician rating on the CGAS. The moderate correlation also suggests that the RSI accounts for significant amounts of unique variance that isn't captured by a clinician's subjective opinions of a child or youth's impairment level. Now lastly, we also looked at the relationship between the RSI total score and other measures. The scale scores are also available in the manual, but I'm going to keep it at the total score level for today. Looking at adaptive behavior, as we might expect, the scores with the ABAS-2, which is a measure of the presence of skills learned to function in daily living, these were associated with RSI scores, which assesses a deficit in the ability to perform those skills rather than the absence of the skill itself. So the median correlation of negative 0.54 suggests that despite differences in their conceptualization, these two scales have a meaningful association. But it's not so strong as to suggest that adaptive behavior and impairment are overlapping constructs. The RSI showed its strongest correlations with the Comprehensive Executive Function Inventory, or CEFI, and the Devereux Student Strength Assessment, the DESA. Now, although these measures may capture different constructs, executive functioning and social emotional competency both have to do with the frontal lobes. So both of these scales are rating measures of how people meet the demands of everyday life. And of course, this is something that the RSI addresses. So these strong correlations were certainly expected. Most importantly, I want to draw your attention to the correlations between the RSI and psychopathology. We were able to demonstrate that symptoms and impairment do not always correspond. We looked at the relationship between the RSI and the Conners CBRS scales, which is a broadband measure of psychopathology in children. And we found only small to moderate correlations. This means that separate measures of impairment and symptoms is warranted. Finally, the lack of correlation between the RSI and measures of intelligence and achievement illustrates that these constructs are measuring things that are completely independent. This suggests that regardless of a child's intellectual ability, impairment can be present and it needs to be assessed independently. Okay, so now I'm going to turn it back to Amy, and she's going to talk to us about administration, scoring, and interpretation of the RSI.
Thanks, Lindsay. I'm going to go ahead and give Lindsay a quick breather there because she just talked to us about the psychometrics of the RSI. But one of the things I'm really curious about is what your experiences are like as a practitioner. So we are going to pose our third and final poll question to you.
Okay, so as a poll question, we're interested in what administration method you use most often. Are you doing online assessment, paper and pencil assessments, and what are you doing for scoring? Are you hand scoring, scoring by software? So if you want to answer the poll. All right, so it looks like a lot of you are still using paper, but there's definitely a trend towards moving towards online, and some of you are using software. So Amy, do you want to talk to us about the administration and scoring options for the RSI?
Sure. Thanks, Lindsay, for doing the poll question. Thanks, everybody, for responding. I'm always curious as a practitioner to see what other people are utilizing in their practice. Now, as mentioned, we are going to be looking at several different ways with which you can administer, score, and interpret the RSI. Now, there's a couple of options that we have with this. The first option is the paper and pencil administration. Now, with this option, what you're able to do is provide both a teacher or a parent with a paper copy of the rating scale. Once they've completed it, you're able to hand score the RSI or use the MHS Online Assessment Center to score the protocol. A second option you have when it comes to administering the RSI is to utilize the online administration. Now, with the online administration, there are a couple of different options you have. The first thing that you're able to do is you can give the parent or the teacher, you just have them come into your office and complete it at your computer or utilize a tablet. Now, the nice thing with this is once they've completed it, you're able to immediately generate the report. But you know what? Sometimes it can be really challenging to get people into your office, right? Well, another option that you have is you can email a link to the rater. Once that individual has completed the rating scale, you're able to get an email notification that they've done it. Once it's been done, you're able to score it utilizing the MHS Online Assessment Center. As reflected here, the MHS Online Assessment Center allows you as the practitioner to both administer, score, and generate reports both conveniently and efficiently. With the RSI, there are 3 different report options. This includes the interpretive report, the progress monitoring and treatment effectiveness report, and the comparative report. Now, in the next few slides, we will be looking specifically at these reports. A nice thing about using the computerized scoring and the reports is there are several features that are useful to you as a practitioner. First, it's great because it's going to save you a significant amount of time when it comes to scoring, because the rater is going to put in the data for you. Now, if you do have to do data entry with the Online Assessment Center, there is an option to have a double entry feature, which is great because you're able to verify the accuracy of the responses. This helps with decreasing the likelihood of error when it comes to scoring the RSI as well. Once the data has been inputted into the Online Assessment Center, you're able to immediately generate reports. Now, when we think about hand scoring assessments versus computer scoring or online scoring assessments, the nice thing with the online scoring is there are a whole host of different options that are readily available to you that you miss out on with the hand scoring. Now, this includes having tables, graphs, and treatment targets for the RSI. There are optional report features that you as a practitioner can say, yes, I'm going to use these, No, I don't need these features. It's all based on your preference. When you generate a report, you're able to save it in either a PDF format or an RTF format. Now, one of the things that I love about our computerized reports is that you're able to copy and paste text and graphs from the reports directly into your comprehensive psychological evaluation. Once you've administered the assessment, you're able to rescore and regenerate reports an unlimited number of times. Sometimes we have a lot of paperwork that we have to manage when we're doing evaluations. Well, the online assessment center is really great because you're able to have everything stored online and are able to use different search terms to find the items online. Now, as a practitioner myself, I refer to the MHS Online Assessment Center as my online toolkit. All of my rating scales are easy to access, administer, and score. There are several options when it comes to using the Online Assessment Center, and these are all of the assessments that are available, including the RSI, which we're talking about today. Let's go ahead and look at some of the report features for the RSI. Now, as I mentioned, there are 3 different report options. There is the interpretive report, progress monitoring and treatment effectiveness report, and the comparative report. Now, I know from doing presentations that when you're looking at this on your computer screen at home or in your office, the text is quite small. So I would encourage you at this point to make sure you download those sample reports because the text will be larger and you'll be able to see all the items that are and features that are on the reports. Also, when we go through the interpretation process, we'll be looking at larger screenshots of the different aspects of the report so you'll get a better idea of what these look like. Now let's go ahead and talk about the first report. The interpretive report provides information about the youth scores and how he or she compares to other youth his age. It's going to note for you if the scales are elevated. A nice feature of the interpretive report is the feedback handout, which you can provide to parents or teachers. Now the feedback handout is great because it summarizes the information for you and describes the scores in a broad, non-threatening term that are appropriate for a general audience. The second option is the progress monitoring and treatment effectiveness report. Now, with this report, you're able to look at 4 administrations from the same rater and summarize important change over time with that individual's behavior. This is especially useful when it comes to looking at the youth's response to treatment, or in the school setting, if you're looking at response to intervention or multi-tiered systems of support, you can use this data to inform your decision making. The final report feature is the comparative report. Now, this type of report, you're able to combine the results of up to 5 raters, and this provides you with an overview of the youth's behavior from a multi-rater perspective. Also, this report will highlight potential differences between the different raters. How does John look in the school setting versus the home setting? Now, there is an interpretation process that's recommended in the manual, and we're going to be going through that interpretation process. I kind of feel like I've left you hanging, and you might be asking yourself, what about John, Amy? What happened to John? Well, guess what? Both John's mom and his teachers completed the RSI, and we are going to see the results of the RSI for John as we go through this interpretation process. This is here for your reference, and really just a reminder that when we're interpreting the RSI, we're going to be looking at T-scores and percentile ranks. The higher the T-score, the greater the individual's level of impairment. The first step in the interpretation process is to interpret the RSI T-scores. Now, this involves examining both the RSI scale scores and the total score. First, we are going to look at the RSI scales. This is important because it provides specific information across the different areas of impairment. Now, the way we calculate the scale scores is we look at the raw scores, we sum up those responses, and then they're converted to T-scores. The T-scores have a mean of 50 and a standard deviation of 10. Now, the reason for this is so that we can easily interpret and compare the results to the normative sample. After looking at the RSI scales, we're going to turn our attention to the total score. The total score provides an overall indication of the youth's level of impairment. Now, while this does provide us with a global look at the individual's level of impairment, the RSI scales are the best indication of the youth's impairment across the specific domains of functioning. The RSI total score is calculated by adding all the T-scores for the RSI scales and then converting it to a T-score for the total score. I think it's so important, I'm going to reiterate it here. When you're looking at the results of the RSI, we want to make sure we examine those RSI scales and not just that total score, because it is possible for the total score to land in the no impairment range. However, the youth may still have impairment in one or more of the RSI scales. And if that's the case, you would want to address it as a practitioner. That's why it's so important that we look at the scales and the total score to get that overall picture for the youth's level of impairment. Let's look at John's results. The RSI report provides you with an overview that allows you to see the T-scores for each of the RSI scales and the total score. Data is available in a graph as seen on this screen. And these are John's results. We can see from just looking at it, he has considerable impairment in the school or work scale, as well as impairment, whether it be mild or moderate, in several different domains or scales. In addition to this, you are able to see the results in a table format. Now, this is a nice feature because it provides you with the interpretive guidelines for each of the different scales and the total score. For example, we can see here for the school work scale and John's T-score, we can see that he has a considerable level of impairment, especially when it comes to acquiring and applying knowledge at school or work. Another feature of the report that we can look at that's important is the specific areas of impairment that were reported by the rater. Now, in John's case, you can see here the specific areas of impairment on the school or work scale. So we know based on the parent report, John is having difficulty with being organized, concentrating, following instructions, getting started at school or work. We're starting to see that John has some significant impairment. As mentioned, this is an example of the parent feedback handout for the RSI, as it breaks down the information in an easy to understand format, and it summarizes the results for you. Of course, as practitioners, when we get the results from something like this, we want to make sure we analyze it ourselves and synthesize it with all pertinent information we've collected as part of our comprehensive evaluation. Now, the second step in the interpretation process is to conduct item level analysis. Each RSI scale can be interpreted more thoroughly by determining the specific items that contributed to a higher score. We want to determine if the youth score for each item is substantially higher than the normative sample for that item. This helps us when it comes to finding specific areas of impairment, and it indicates behaviors that may be a priority for intervention or treatment. Now, it's important to take this step because an RSI scale may not be elevated. However, one or two of the items within the scale may be elevated and warrant further investigation. So, for example, here, when looking at John's results in the item by scale section, you can see the different responses. In John's case, we can see he is often having difficulties in the school or work scale. And the items are shaded for us to tell us that is significant. The third step in the interpretation process is to compare the results across raters. This can really help us determining if there are consistencies or inconsistencies across environments. Let's talk about an example. We may have a child who is not able to concentrate in school or in his classroom because it's noisy or there's too much going on. However, at home, he may be able to concentrate better because there's less going on. So it's important for us to consider that context. Here is a graph display of John's ratings based on the raters across the different scales. We can see the parent as well as 2 teachers who completed the RSI on John. Again, the data is also available in a table format. Now, I like the table format because it summarizes the data for you, and as you can see in John's case, he appears to be having considerable impairment according to both parent and teacher raters in school, as well as the social scale. Now, I think it's important to note here where it says no comparison possible for the domestic scale, family scale, and self-care scale. The reason for that is those items are not assessed on the teacher version of the RSI, as they would not really be appropriate. Another way with which we can look at the data is in a bar graph format. Now, based on what we've learned about John earlier, we know he meets many of the symptom criteria for ASD. We even did the Autism Spectrum Rating Scale, or the ASRS, to evaluate his symptoms. And in looking at the RSI data to help us with determining his level of impairment, it's clear that he has a significant impairment that's impacting him in multiple life areas of functioning. Specifically, concerns were noted on the school and social scales of the RSI. Now that we know this, I feel pretty confident as a practitioner saying John meets criteria for ASD and looking at what we can do from there. Now, as practitioners, we don't stop here in our evaluation process. And that leads us to our fourth and final step for the interpretation process. What we want to do here is we want to compare results across time. As a practitioner, I love the fact that I can use the RSI to monitor progress over time, and it helps in determining if a treatment program is effective or if it needs to be adjusted. The RSI report provides information on both the statistical changes of the scores over time, as well as whether or not they're meaningful. Let's look at John's results here. Again, here's the data from the first administration through the third administration in a visual format. We can see his level of impairment looks like it's decreasing. In addition, this table synthesizes the data between administrations and looks at if there are any significant increases or decreases in John's observed impairment. As we can see here in looking at this information, we can see here from comparing the first administration to the third administration for the school work scale that there's been a significant decrease. There was no change on the social scale. There's also a significant decrease on the domestic scale for John from the first administration to the third administration. Now, this information is important because it helps us with determining if the interventions or the treatments we've put in place are effective for John. Looking at this data, I feel confident that the interventions and supports are working for him. Now, with putting those supports in place, John has shown improvements with his transition to high school. Now, we really just went through the interpretation process and we did look at some data for John, but to really wrap up this presentation on our webinar with the time we have left, one of the things we want to do is do a case study example for Megan. Now, let me tell you about Megan. Oh, Megan. Megan is 11 years old and has a history of difficulties in both social interactions and a consistent pattern of disruptive behavior. Megan has received multiple treatments for her disorders, including being identified with autism spectrum disorder, obsessive compulsive disorder, attention deficit hyperactivity disorder, and anxiety disorders. Currently, she takes multiple psychiatric medications to help manage those symptoms. In addition to this, it's evident that she's exhibiting a number of impairments in both the home setting as well as the school setting. Knowing this, it was determined that an in-depth assessment of Megan's functional limitations be conducted. Now, this was determined so that we could assist with treatment planning and help Megan be more successful in both home and school. As part of this, it includes doing interviews with both Megan's parents and her teacher. Of course, we're going to also complete some rating scales, including the RSI, and administer a battery of assessments. When Megan's parents were interviewed, they provided a host of information to better understand her needs. This included looking at her developmental history, her medical history, and academic history. Megan's parents shared that she is the second of 4 children, and her siblings range in age from 4 to 19. Her parents shared that even from a young age, she's been a difficult child. Megan was described as being very active, having a difficult time when it came to approaching new situations, and being extremely anxious. While currently, Megan does receive special education services, but she is continuing to struggle in the regular classroom setting. Some concerns her parents shared include having difficulty concentrating, following instructions. Her parents shared she oftentimes looks very disorganized and loses her belongings. She oftentimes will lose that book bag, her homework. Parents don't know what she's done with it. At times, Megan can be very uncooperative when it comes to helping with chores around the house. This includes cleaning her room or taking the trash out. Lastly, Megan displays a range of both disruptive and non-disruptive behaviors. Now, these behaviors include things such as emotional distress, hyperactivity, inattention, and anxiety. Now, when we sat down and talked to Megan's teacher, many of the concerns that her parents shared were echoed by the teacher. Some of the concerns that Megan's teacher noted included that Megan is struggling academically. She appears to exhibit many of the behaviors of ADHD, which include being inattentive to what's going on in the classroom, as well as being hyperactive and impulsive. In addition to this, her teacher shared that Megan tends to exhibit many of the behaviors associated with autism spectrum disorder. Megan completed a number of assessments. Of note, she scored lower on the working memory domain of the WISC-4. When the CAS-2 was administered, she also scored lower on both the planning scale and the successive scale. Now, Megan's parent and her teachers completed the Comprehensive Executive Function Inventory, or the CEFI. Now, the CEFI is designed to assess youth's strengths and weaknesses in executive function. If an area of weakness is identified, recommendation or intervention strategies are recommended in the report. Areas that were noted of concern for Megan included attention, organization, planning, and self-monitoring. Now, we've gone through all of the assessment data with the exception of her RSI results. This is for your reference and a reminder of the recommended interpretation process for the RSI. Let's go ahead and look at the results of the RSI for Megan. Both Megan's mother and her teacher completed the RSI to determine the extent of her impairments at school and home. An analysis of the RSI results provides a strong picture of her level of impairment that she's currently experiencing. Now, according to the ratings obtained from Megan's mother, She demonstrates considerable impairment in the school and domestic areas, while moderate impairment was noted in the social and family areas. No problems were noted on the mobility scale. Overall, when looking at her total score, considerable impairment was noted based on parent input. This indicates a substantial overall level of impairment that Megan is experiencing. Now, in addition to having Megan's mother complete the RSI, her teacher also completed it. Megan's teacher noted a similar pattern of impairment for her. This included considerable impairment in the school domain, mild impairment in the social domain, and no impairment in the mobility domain. In addition, Megan's total score noted mild impairment. Now, when comparing the ratings from Megan's parent and teacher, there were some significant differences, specifically on the school domain, with higher ratings provided by Megan's parent compared to her teacher. Now, this difference indicates that Megan was rated as significantly more impaired in the school domain by her parent than her teacher. Megan's parent and her teacher both noted impairment in Megan's functioning in the social domain, with no significant differences between the two. Also, both her parent and teacher indicated no impairment in the mobility domain. It's important to note that while differences exist between the parent and the teacher ratings, there was some overlap on the items that both Megan's parent and teacher noted as areas of impairment, which we'll look at in the next couple of slides. When comparing the results obtained by Megan's parent and teacher, this really highlights Megan's impairment in school and her difficulties when it comes to both acquiring and applying knowledge in those settings. This also really looks at her impairment in socializing and interacting with others. In looking at these results, it's clear that that we may want to do some additional examination of her performance in both the domestic and family areas. Now, given that the domestic and family domains do not appear on the RSI teacher form, no comparisons were made. In addition, since the total score on the teacher form and the parent form are calculated using a different combination of scales, there's no comparison made there as well. Now, based on the assessment results, it is evident that Megan needs additional supports at home and at school. The results of the RSI can be used to help with treatment planning. Now, this is one example of one of the areas of concern from Megan's RSI report. If you were to generate the report, you would have all of the scales listed. Now, I really like this feature because you have the parent and the teacher side by side and you can make some comparisons. For example, in looking at the parent version and the teacher version, concerns were noted by both raters for being organized, learning at school, finding solutions to problems, and the list continues on. Now, I think it's interesting to note there's no overlap noted by the parent and the teacher when it comes to starting her schoolwork. That was something that was only indicated on the parent report when they completed the RSI. Now, given the complexity of Megan's symptoms, her multiple disorders, and this continued level of impairment she's experiencing, her treating psychiatrist requested a meeting with Megan's family, the therapist, and the education team at school. Prior to making any changes to her psychiatric medication, the psychiatrist requested that there be an increase in supportive services for her at school. Now, the team determined that Megan qualified for an individual aide at school. The aide at school was assigned to support Megan and one other special education student during their mainstream time in the regular classroom. Additionally, Megan's family was referred to an in-home behavioral therapist to provide further skill building for Megan, as well as parenting strategies for her mom and dad. To address Megan's feelings of anxiety and her concerns with feeling disliked by her peers, she began working with a cognitive therapist on a weekly basis. Additionally, a response cost system was initiated at school. This focused specifically on Megan's behavior in the regular classroom setting. Within a short period of time, improvements were noted. Now, I mentioned that improvements were noted for Megan, but you might be asking yourself, well, how do you know, Amy, that Megan has improved? Well, let's go ahead and look at our progress monitoring data and use that to help support that decision, as well as that statement. Here's the progress monitoring data based on Megan's parent report. Both Megan's mother and her teacher were re-administered the RSI for a second time 2 months after the initial administration. Based on Megan's parent ratings, some interesting things were noted. On the second administration of the RSI, considerable impairment in the domestic domain was noted, as well as moderate impairment in the family domain. No impairment in school, social, or mobility domains were noted. Her total score on the RSI indicated a mild overall level of impairment. Thus, we see a decrease for the school scale and the social scale for Megan. The same can be said for the total score. When we compare Megan's mother's ratings from the first to the second administration, we see all these significant differences between the first and the second administration. This really indicates that her overall level of impairment has decreased. In addition to administering the RSI to Megan's mother, her teacher also completed it. Megan's teacher ratings on the second administration of the RSI indicated no impairment in any of the school, social, or mobility domains. Her total score also indicated no overall level of impairment. Again, this really iterates the fact that Megan's impairment and some of the concerns that were being seen at school have decreased. Based on the assessment, she was identified and received appropriate services to help improve her relationships. As you can see, when we administered the RSI, we were able to help determine where Megan's impairment was most prevalent. We saw impairment for her both in the home setting as well as the school setting. Then, after looking at all of our results, we were able to use them to help inform our decision-making with treatment planning. After implementing intensive levels of support at both home and school, we saw improvements with Megan's overall level of impairment. Now, as we near the end of the webinar today, let's review the objectives we've covered in our time together. First, we've looked at the definition of impairment and how that varies across the different disciplines. Then we also talked about how the definition impairment was operationalized for the RSI. Second, we looked at the role of impairment in the diagnostic process and why it is so critical to include it as part of our comprehensive evaluation. This included looking at past practices and current practices for assessing for impairment in youth. Third, we looked at the essential features of the RSI. For the fourth objective, I turned it over to Lindsay and we looked at the psychometric properties of the RSI. This included looking at the standardization sample, the reliability, and the validity. Fifth, we looked at the RSI and how you're able to administer, score, and report the results with the RSI. This included being able to administer the RSI by hand or using the online assessment center, as well as being able to generate multiple different types of report options, including the interpretive report, the comparative report, and the progress monitoring and treatment report. Lastly, we took all of this information and did a case study example where we looked at Megan. We looked at her results and compared them across raters, and then put interventions and supports in place and looked at her progress monitoring data. Throughout this webinar, people have been submitting questions for Lindsay and myself to answer. If you have any questions that you haven't asked yet, we encourage you to submit them now. We are going to try and answer as many questions as we can in the remaining time that we have together. Now, after the webinar, we will be sending out all responses to all the questions that are submitted.
Okay, thanks, Amy. I've actually been monitoring the questions as they've been coming in, so thank you so much for those who've been participating and sending in questions. There's some great questions here, and we'll try to address as many as we can. It looks like we do have some time for questions, so that's great. We should be able to get to a bunch of them. So me and Amy will just sort of trade off here. I'll kind of glimpse at the questions and see who's best or most appropriate to answer the question that's being asked.
Sounds great.
So one of the questions that came in, somebody said, I'm a school psychologist and I don't really do any diagnostic work. I focus more on intervention and accommodation, so how would the RSI be useful for me?
You want me to answer that one?
That sounds like you.
Okay. I probably should since I'm a school psychologist. Great question. Thanks for submitting that question. You're right. In many states, including where I worked as a school-based school psychologist in Florida, we are not required to provide a diagnosis based on DSM-5 criteria. And I know that's the same across many other states. Rather, we're looking at special education eligibility requirements to determine whether or not a child meets requirements for special education services. Now, as part of this, we, along with the eligibility team, have to ask the question, is a youth's disability causing significant impairment that is impacting him or her in a way that is educationally relevant? Meaning, if I'm going to find a student eligible for ADHD under other health impaired, then I need to think about its impact in the school setting. Now, the RSI is an excellent tool that you can utilize because it can help with determining whether or not the youth has an impairment in the school work scale, social scale, and mobility scale. But I think there's another piece to this question that is worth answering because it was asked, what about focusing more on intervention and accommodations? Now, I think this is really important because as a practitioner, I like the RSI, especially when it comes to problem solving and implementing interventions. When you as a practitioner determine that a student warrants an evaluation for services, this is a decision that's based on data. We are able to administer the RSI to help us with determining what interventions would benefit the student, and then you're able to use the RSI data to help with progress monitoring and determine whether or not the intervention is effective. Now, I've been a special education teacher and a general education teacher prior to becoming a school psychologist. And I used to get frustrated with all the paperwork I had to do, whether it was writing an individual education plan, going to a meeting. So one of the things I'm mindful of as a practitioner is if I'm going to give a rating scale or ask for input from a parent, teacher, or even a self-report, I want to make sure it's a judicious use of time and resources. Now, knowing that the RSI takes 5 minutes for a teacher to complete or 10 minutes for a parent to complete, I don't feel like I'm overwhelming them with this task. So thanks for submitting that question. I would say overall, I think the RSI is a useful tool, even if we're not looking at diagnostic decisions.
Thanks, Amy. That was a really complete answer. I've got one here about the norm sample, and somebody's asking, is the norm sample a true normative sample, or is it a general population sample? I actually am really glad that somebody asked this. We must have some psychometricians on the line here because there really is a difference between a norm sample and a general population sample. So the language does matter here. So although people typically just refer to the norm sample, when you say that, you mean that it really is normative, that it's a sample of people who are free of any kind of disability. What our norms reflect in the RSI is a census-matched general population sample. So of course in the general population, you just don't have a bunch of people who are completely free of diagnoses. There's a lot going on with people in the general population. This means that we have both individuals free of disability that match the US Census in terms of demographic variables, but it also includes youth with a clinical diagnosis or those who are eligible to receive special education services according to IDEA criteria, or the Individuals with Disabilities Education Act, that are in proportions that are similar to the number of youth that are enrolled in public schools who are receiving educational services under this act during the time that we were doing data collection. So thanks for asking that question. I've got another one about the norm sample here. It says, what type of diagnoses were included in the physical disability group that was used for clinical validation samples? So to answer that, I'll just say we collected data from individuals with musculoskeletal disability. So this included people with muscular dystrophy, myalgia, and scoliosis. All right.
I have one right here. So a question that just came in is, how often can the RSI be given, or how often should I be using it for progress monitoring? Well, when we looked at the directions, when we talked about the key features of the RSI, the directions state that the rater is supposed to rate the individual's behavior over a 4-week period. So I would recommend that if I were to utilize the RSI for progress monitoring, I would want to wait a minimum of 4 weeks between administrations of the RSI to determine whether or not the treatment is effective. Now this I think is important, because then that allows for time for the individual's behavior to be changed based on the treatment or the intervention that's put in place.
Amy, that question works perfectly with the next one I've got here. Somebody said, would you re-administer only the scales that demonstrate a deficit, or would you re-administer the entire RSI? So what we would recommend is that you re-administer the entire RSI and follow the standardization. And this really shouldn't be a problem, because it's really a short and quick measure to re-administer. We're talking about 5 or 10 minutes, so it's important to look at the whole picture both times. All right, so here's one that's more comprehensive. I think you talked a bit about it in the webinar, but it's probably good to go over it again. So somebody's asking, how does impairment differ from symptoms?
Okay, you want me to take that one?
Go for it.
All right, I'll take that one. Thanks for submitting that question. So one of the things I think that's really interesting when we think about the diagnostic process is the role of impairment is complicated. And oftentimes it gets confused with symptoms. So when we're thinking about symptoms, those are a physical, cognitive, or a behavioral manifestation of a disorder. Now, impairment is different, because impairment is the functional consequence of the symptoms. Now, it's generally pretty true that the greater the number of symptoms somebody has, the greater that severity, those symptoms tend to result in more impairment. So as one has an increase in symptoms, you typically see an increase in impairment. But that's not always the case. The relationship between the two is more complicated than that. Sometimes, for example, there are people who meet the specific symptom criteria for a diagnosis, but they are not experiencing a clinically significant amount of impairment in a major area of life functioning. On the other side of the coin, there are some people who are experiencing a significant level of impairment, but don't meet the symptom criteria for a diagnosis. Now, this is somewhat complicated, I think, when we're talking about the two, and it would be better understood within the context of an example. So I think a good example of this is when we're talking about a child who has attention issues. So thinking about working with kids and families, one of the things that comes to mind is meeting with a parent and talking to a parent because they say, hey, Amy, my child is having some attention concerns. So the parent goes on to tell me that the child is having low levels of attention. Now, telling me that the child has low levels of attention is really just describing the symptoms, but it's not telling me about the impairment. If I were to sit down and continue talking to the parent and she were to say to me, Amy, while my child has attention problems, sometimes he's able to sit at his desk and complete beautiful pieces of art. And if he's doing art, there's no problems. He just is able to attend to that task. Now, she's describing specific behaviors in a different context, but it's not really touching on the youth's level of impairment. So I know that there are attention concerns, but sometimes if the child's doing art, the child's able to focus. But as I dig deeper and talk more to the parent goes on to tell me, Amy, my child has trouble when it comes to getting started on his homework. Even when he starts his homework, he has a hard time completing it. It's a struggle. We oftentimes will stay up late trying to finish it, but most of the time we don't even finish the homework. And then when I send him to school in the morning, he forgets to turn it in when I touch bases and follow up with the teacher. Now that reflects impairment, how the individual's level of attention is impacting their functioning in everyday life.
Okay, great. Thanks, Amy. We also have one just about sales, so I think that's you too. They're just saying, how is the RSI sold and what does it cost per administration?
Oh, okay. Well, as an assessment consultant in the Southeast, I have a team. There's a team of us that support both the education market and the clinical market. There are multiple options that you have when it comes to ordering the RSI. You can order the online kit as well as the hand-scored kit. There's more information in the brochure that's attached to today's webinar. You'll be seeing the contact information also for the assessment consultants in the next couple of slides once we wrap up with our questions. One of the things I will tell you as an attendee for today's webinar is if you would like, you're welcome to contact me or your assessment consultant, and we would be more than happy to set you up with a free trial of the RSI using the MHS Online Assessment Center. That way you could see the features of the RSI with administration and the scoring options with the different reports. Your consultants can share with you the costs associated with purchasing this assessment, as well as what discounts are available to you as well.
All right, I'll give you a break because there's another psychometric question here. Somebody's asking, what happens if they give the RSI and the rater forgets to complete one of the items on the assessment? So you are able to score the RSI even if the rater has completed the RSI but skipped some items or skipped a item. We use a prorating procedure to score the RSI. So this provides the best estimate of the child's level of impairment in the presence of those omitted items. And the manual gives more details about how the prorating method for omitted items works. So omitted items also affect the total score and may overestimate or underestimate the true value of impairment. So if more than one item is omitted on a scale, then the score for that scale and the total score aren't calculated, and therefore they won't be reported. Amy, somebody wants to know about languages. We did mention Spanish, but do you want to talk a little bit about the Spanish version?
So being from Florida, I love the fact that the RSI is available in both English and Spanish. So you're able to target a larger demographic when it comes to assessment, especially when it comes to being culturally sensitive. Now, with our Spanish translation of the RSI, this was developed once the RSI English version was created. I love the fact that it's not a mere translation using a web browser to translate it word for word into Spanish. Rather, we had two psychologists who we worked with to develop the Spanish translation. What they did was something called backwards translation. So they took the English version of the RSI, they translated it into Spanish to make sure it made sense, and then after translating it into Spanish, it was translated back into English. This backwards translation process ensures that the content of the items remains despite the fact that it's been translated from one language to another. Now, if there are multiple variations for an item or a word, what we did was we wanted to ensure that we chose the word or the phrase that was most representative for the language.
Okay, I think we can squeeze in one more question. I'm sorry if we didn't get to your specific question, but we do have time for one more, and it's just somebody asking who's allowed to administer the RSI. So I guess what qualifications that you need to have?
Yes.
So go ahead, Amy.
Okay. So with the RSI, like many of our assessments, they do require what we call B-level qualifications. Now, B-level qualifications mean you've had graduate coursework and test and measurement, or you've completed documented training for the assessment, which is really what we're doing right now as part of this webinar. Of course, it's important that we follow all the rules and regulations by our licensing and certification boards when it comes to the administration and interpreting of our assessment tools. So in general, if you're a psychologist, school psychologist, psychiatrist, anybody with a graduate level coursework in test and measurement, you'd be eligible for the administration of the RSI and many of our other assessment tools. Sound good?
Yeah, great. Thanks everybody for your comments. I think Daniela wants to wrap it up here for us.
Okay, great. Thank you so much. So on the next couple of slides, I think we have just a breakdown of the assessment consultants. So this shows you the education consultants, and it gives you the names. That's color-coded to show you who your representative is in that particular state you live in. And this is a map for the clinical reps. And as well, we've got Lindsay's information on this, as well as Claudia Roy, who is our international consultant. And here, if you prefer to connect on Twitter, thought we'd provide that information for you here as well. Please visit our Learn Center at mhs.com/learn, and there you can take a look at other ways that you can earn APA CE credits or NASP CPD credits. You're going to find different options on how you can learn about and earn those credits on some of our more popular products. So I encourage you to take a look at that. And once again, just want to thank you for taking time out of your busy day and participating with us on today's webinar, and have a great rest of your day.
Happy holidays.